sets of genes and has a very good chance of getting hemochromatosis.
We are joined now by Marie Warder, who's the president of the Hemochromatosis Society. Tom, a victim of it, and from downtown Vancouver, Dr. Urs Steinbrecher, or is it Steenbrecher, who is a liver expert and knows quite a bit about this. Thank you all for coming. You must feel kind of vindicated now that this is finally getting attention.
I don't think vindicated is the word, Jim. It's excited because now there's hope for so many people who might perhaps die without being diagnosed in time.
How did you find it? How did you get interested? When was Tom diagnosed?
When he had been really very ill for 7 years and had only 12 weeks to live, on his 50th birthday, that was when he was first admitted into hospital to start treatment for hemochromatosis. And we just accepted it, you know, one of these dreadful things that can happen to people, but only when our daughter developed it at the age of 32. And we knew then that it was hereditary. We knew that women did get it. We knew that young people could get it. And we knew that we had proof that many of the accepted theories were not correct. That's when we decided that perhaps something should be done about it.
Tom, I kind of expected to see a guy with a deeper coloring. You'd have that bronze character.
Yes, I did have a deep color. In fact, we have photographs showing my tan quite distinctly. It was quite, in contrast to other people's skin, you could see it was a deep tan. And it was quite nice at that time, till it started to affect me physically. But since I've been on phlebotomy on these bleeds for several years now, or 10 years, the tan or the pigmentation in the skin has left me, and it's given me a natural color now. But there still are parts of my body that have the deep tan color to it.
Urs from downtown, how did we get onto this business of detecting who has it? What was the development there?
Well, I think there's a couple of things that are really involved. First of all, the disease itself is caused by an inability of the body to regulate the amount of iron that it absorbs from the intestine, from the diet.
Right.
And what that leads to is it leads to iron accumulation in the tissues and also in the blood. And once that was recognized, it became easy to measure the iron levels in the blood, which is one of our best screening tests for identifying the disease. There are tests available that allow us to determine the amount of blood that is, the amount of iron that is carried in the blood, and that lets us identify with reasonable confidence patients who do have the disease.
That's a simple blood test, go to the doctor and you get it?
That's right. Now, once you've identified somebody who you know to be a homozygous subject, that is, he has both two abnormal genes for the disease, then you can use genetic analysis to determine whether his relatives, his brothers and sisters, or his offspring might also be affected. But you can only do that if you have an affected individual in whom you can characterize by genetic methods. But for the general screening, you'd have to rely on measurements of iron levels in the blood.
This business of bloodletting, that sounds like it's out of the dark ages. Is that really the best way to treat it?
Well, as a matter of fact, it is. The disease is caused by the body absorbing too much iron, and the richest source of iron in the body is the blood, because there's iron in the hemoglobin in red blood cells, and it turns out you can remove iron more quickly, more easily, more safely by just removing blood than you can any other way.
Is this a stopgap treatment in the way that insulin is a stopgap treatment rather than a cure for diabetes?
It is in the sense that we don't know how to cure the primary problem, which is the inability of the intestine to regulate iron absorption. However, it is a very good stopgap treatment, if you want to call it that, in that if you can remove the iron adequately, and you can do that in all individuals who are followed and who are treated appropriately, you can prevent all of the serious manifestations of the disease.
They said for a long time that women didn't get hemochromatosis. Why was that?
Well, it turns out that what the disease does is it gives you a condition where you can't regulate iron absorption, but the amount that you actually absorb is dependent on a number of things, including how much iron you take and how much blood you lose. Now, it turns out that women, because of menstruation and pregnancies, lose quite a bit of iron in excess of what the average man would lose, and therefore it takes them much, much longer to get the disease. And so that women, when they do get it, they tend to be in their 70s.
So in the last few years, we've become very concerned among women with iron deficiency, but for hemochromatosis victims, that would have been a good thing.
Well, actually, the iron deficiency thing and supplementation of various foods with iron may actually have led to an increase in the number of patients who are detected, because the number of patients who will get sick with the disease, who will develop like iron overload, is determined by environmental things like the amount of iron in the diet. So in fact, iron supplementation is worse in a population where there is a substantial prevalence of the gene for hemochromatosis.
How are you now, Tom? How often do you go for bleeding? Gee, I hate to use that word.
I was being bled on a regular basis initially twice a week. And that was for a couple of years, well, a couple of months.
Wow.
Then for several years, I was bled once a week, a pint a week.
Yes.
And then as the iron level decreased, they monitored it and eventually found that I wouldn't need a bleed for, say, every 2 weeks and sometimes 3 weeks. Now, it's every 3 months.
Gee, that's not bad.
It's not bad at all. It's the same as a blood donor would do now.
Do you still have arthritis? And
Yes, the arthritis is staying with me, and it's getting worse, actually, but this is something I've got to live with, mainly in my hands. But the other side effects that I had, the diabetes has stayed with me, too. My pancreas is destroyed from the iron. That's another place it lodged.
So the iron buildup destroys the pancreas?
And the liver, yeah. Well, it goes to the liver first, and the pancreas is another place it goes to.
Does that mean you don't get to drink on New Year's?
Well, I have a good doctor. He knows what I should have.
I want to ask Urs about carriers. 1 in 10 of us as carriers, need we worry?
Carriers never develop symptoms of iron overload. So the only thing that one needs to be concerned about if one knows that one is a carrier is the possibility of transmitting the disease.
How does one find out if one's a carrier?
Well, you would only really be in a position to find out if you had an affected relative, and it could be identified with genetic analysis using HLA typing.
Some of us must be sitting at home saying, gee, I wonder if I fall into this category. What are the things to watch for?
Well, there's nothing to watch for if you're a carrier. And the symptoms of the disease are related to the organ systems that it attacks, and those have already been mentioned. You know, it can produce symptoms of diabetes. It can produce liver symptoms. Usually it's detected because we now, when you see a doctor, it's more common to get blood tests done that will check the liver function. So often you can pick it up before the disease has progressed to the stage of cirrhosis, which may not be reversible. And the same thing is true, it can affect the heart, and you may get symptoms of heart failure. Now, it turns out that the heart failure and the liver problems are at least partially reversible with the treatment, whereas other things like the arthritis tend not to improve once the disease has established itself, even with appropriate treatment.
What do you tell someone, Marie, if somebody phones and says, gee, I've heard about and I wonder if I have hemochromatosis?
I say to them, if you have a reasonable doctor, ask him to give you a blood test or to requisition for a blood test, because at least if it shows that the transferrin saturation is below a normal level, then you're safe. If the transferrin saturation or ferritin levels show that they're dangerously high, well, then take it further. Go and see somebody like Dr. Steinbrecher.
Thank you all for being with us, huh?
Some doctors say is relatively common and easy to prevent, but it's often misdiagnosed or missed altogether, and with tragic results. This is also a story about a Vancouver woman who's watching her husband die from the disease, and she wants to make sure that what's happening to her husband doesn't happen to others. CBC's Eve Savory introduces us to the Warders.
For 35 years, Tom and Marie Warder played together in a band. But over the years, Tom Warder's hands have become thick and awkward with arthritis. His diabetes is a constant aggravation. And now a massive cancer growing in his liver means he may not see the summer. And it didn't need to happen.
My whole business is too late. Everything happened too late. Diagnosis was too late. It's preventable. The whole thing is preventable.
Few have heard of his disease, and yet
1 in 10 people in the general population who are of Caucasian descent, European descent, are carriers for this disorder. This is not an uncommon illness. This is very, very